Hello, everyone. Welcome to Psychiatric Times and ASCP's podcast. My name is Dr. Jenessa Johnston, and I am ASCP's social media coordinator as well as a research fellow at the NIMH. And today I am joined by Dr. Jill Harkavy-Friedman and Dr. Elizabeth Ballard, who will be talking to us about targeted interventions for suicide prevention, their recent panel at ASCP. So I first kind of wanted to ask you a few questions based off of your panel today, which was wonderful. Thank you so much. Suicidal ideation and behavior really occur across many neuropsychiatric diagnoses. It's not just depression, it's not just bipolar. And do you really think that our current, more diagnosis-based framework has limited our ability to research this kind of symptom domain?
In a word, yes. I think that suicide is the leading cause of psychiatric-related death, and we know it occurs across diagnoses. And I think a lot of what's happened in our research literature is somebody does a main study, depression, bipolar, and then you do a secondary analysis related to suicide. And there's a lot of limitations of this because it's not powered to answer a suicide-specific question. It's not designed to answer a suicide-specific question. And what we know, and I'm sure Jill will inform us more, is suicidal individuals are often excluded from those studies. And so what we have is a number of people who are at risk of suicidal thoughts, behaviors, and deaths who aren't being studied at all. But I'm interested to hear Jill's perspective on that.
So the way I think about diagnosis is it's a way for us to communicate with each other, but they're not entities in and of themselves. And having worked in the area of diagnosis from DSM-3, 3R, 4, 5, 5T, the criteria change because we're learning more. So I think our whole frame of only focusing on diagnosis is really the issue. I think we need diagnosis to be able to communicate with each other. And we know in suicide, people often have more than one diagnosis. So the most prominent diagnoses are often depression, psychosis, bipolar disorder, and substance use. And when you look at suicide and diagnosis, one of those is always present, right?
Mm-hmm.
So, but suicide has its own biology and psychosocial origins that can be studied alongside diagnosis. So it's always important to have a careful assessment of diagnosis, but again, suicide cuts across. So you always have to be, if you're looking at suicide in people who have depression, that might be different from people who have, let's say, schizophrenia. But the suicide aspect may be the same across those diagnoses. So it's mostly an importance of characterizing who we're talking about when we're talking about suicide. The other thing is that we know that treating a mental health diagnosis doesn't necessarily reduce suicidal ideation and behavior. And so we have to be mindful of the suicide trajectory in and of itself and what contributes to that, along with what contributes to diagnosis. But we do know that 90% of people who die by suicide have a mental health condition, and probably one of those four among what else. For some reason, people debate about that because to me, that's just negative attitudes about mental health conditions. Because I personally think that when people feel well, they don't want to take their life. But suicide is more complex than that. It has to do with decision making. It has to do with weighing of risk. It has to do with emotion regulation, ability to control your behaviors, and so I think it's just much more complicated than diagnosis, but I think we need to understand who are we talking about in that moment and how are they thinking and feeling.
And we had such great presentations today, we didn't get a lot to discuss, but what was striking in the panel today was there were a couple of different treatments. We had psilocybin, we had a therapy, we had a medication, and really there was nuance about sort of what reduced suicidal thoughts as compared to depression. I remember when I was starting out in the field, I studied ketamine, and there were definitely people who were like, well, yeah, of course it impacts suicidal thoughts. That's exactly what depression is. And I had to keep arguing, no, they're distinct. And it was really nice to see that across different treatment approaches, that you did see this differentiation, and some of them didn't have a suicidal thought effect, but it did have a depression effect and the reverse. And so that was really nice to see, again, across different types of treatment.
And I think we can do that now because we've taken suicide out of the depression section of all our inventories, which I worked on a genetic study in the early 1990s, the previous century. And I was already studying suicidal behavior, and I had to fight to get suicide out of the depression section of the diagnostic interview. And at first I got half a page, like 3 questions. Then I got a full page. And now in that interview, it's 6 pages. And all the other interviews also do that because, again, it has its own biology and psychology and social implications, which we need to understand. Because most people with mental health conditions are not going to be at risk for suicide or take their lives. And so we need to understand those diagnostic groups as well.
Definitely. I think following along with that, how do we properly power and design studies to look at suicidal ideation and behavior versus, say, a diagnosis? Obviously, it's somewhat more rare than, say, depression or bipolar, and I know a lot of researchers and clinicians can be hesitant about enrolling suicidal ideation and behavior within their population. In fact, sometimes it's even exclusion criteria, which seems to be doing the opposite of what we want to target. So just how do we go forward in designing these types of studies?
So at American Foundation for Suicide Prevention, we actually require it as part of the study. We've been funding research since 1987. And we say, suicide has to be in the study. But what we mean by that is there are it's a relatively infrequent event. So, and we do fund studies that look at people who've died by suicide, which is a very important component because we need to understand what's different between them and the proxies we use, like having made a suicide attempt or thinking about suicide. And we know most people who think about suicide are not at risk for suicide, luckily, and will hopefully never engage in that behavior. And even people who've made an attempt, 90% of them will not die by suicide. So it just shows it's not a continuum. It makes me think of the Venn diagrams that we learned in school and wondered if we would ever use them. And this is a great use case for a Venn diagram because they overlap, but it's not you go from here to here to here, but they're distinct differences. So because it's so hard the sample sizes are so small for people who die by suicide, we use things like psychological autopsies and medical records to try and recreate what happened for them. And we have the National Violent Death Reporting System, which is great. AFSP has advocated for it. But the limitation is that the information comes from the police and the coroner and the recent medical records. Nobody else is asked. But then we also have to characterize people who've made suicide attempts. And for our studies, if you want to study suicide risk, then you want to study the people who have moderate to severe suicidal ideation. Not to say that other people aren't, important or they may have other reasons that they're thinking about it. But if we want to get closer to suicide, so we say you have to either have mild to moderate to severe suicidal ideation, recent, preferably suicide attempt, or somebody who's died by suicide. Now, we also fund research where people will try to educate people about suicide. That counts. People always call and say, well, this isn't specifically about suicide, suicide death. They were like, anything related, educating people is an important part too.
And I'll just speak to implementing suicide-specific research. And so first and foremost, if you are considering doing this important work, it's really critical to reach out to other people who have done this before. And the nice thing about AFSP is you get connected to other investigators who have done this, and certainly they encourage having somebody with suicide expertise on your panel. But it's not just a question of, oh, we'll just enroll these people and everything will be fine. You need to think, prospectively about how are you going to assess, how are you going to monitor. If you're going to have factors that lead somebody to be excluded from the study or withdrawn for the study, how are you going to do that? Prepping the IRB for these questions. Oftentimes the IRB needs to be educated. And I think there's a whole network of people who've done this work, who know what are the critical risk studies, asking about suicide is not heterogenic. What will we do to make the IRB feel better with this study? And so if somebody's thinking about this, there's the issues, like you said, of power. Suicidal behavior and death is a very low base rate phenomenon. So usually, as Jill said, we're enrolling people with suicidal thoughts and behaviors. But there's all of this intensive monitoring. And so what we wouldn't want is somebody to embark on this and then not have sort of done the legwork, and then sort of the study does not move forward because of that. Because there's such important research, there's still so many important questions, especially as related to treatment, that our patients need. And so we need to give sort of additional resources and additional thoughts about how we're going to recruit, enroll, and then monitor those patients safely.
And then on top of that, just to add, is that we want people who know about suicide to guide the studies, because you also need to think about you need to understand suicide to know what other things do you have to measure, right? And so if you understand, for instance, groups that have higher rates or factors that are known to contribute, you might want to assess those things. You might want to, and measure them. So you definitely want somebody who knows what do you need to consider when you're developing a study. It's a highly rewarding area to do research in, I have to say.
I've also heard nothing but wonderful things about AFSP and their program. So I'm sure also if you're interested in listening, definitely reach out to them. And they are of huge help from what I've heard.
Yeah, AFSP, if you go to research at afsp.org, if you were thinking of applying to a grant, then it would be grants manager at afsp.org. And we do everything related to suicide research.
I also know that both of you discussed kind of today and within the panel, a common theme was really coming up that people just really appreciate being in treatment, not necessarily placebo or active control. There's still a lot of decrease in suicidal ideation with just being in treatment and having clinicians surrounding you. How do you think we could implement even that finding into daily clinical practice?
Well, I think one of the most sort of powerful classical studies related to suicide behavior is something called caring postcards. And that just what they did, Jerry Amato did a study with recent inpatients who were at risk for suicide, and they were randomized just to receive a caring contact, just a postcard saying from the clinicians, "We're thinking about you, hope all is well." We weren't even required to do anything. And so that's always the classic example we give in suicide research. And just that was associated with reduced rates of suicide attempts and death. And so whatever we can do in terms of treatment, to instill hope and instill connection, I think is really powerful. There's been, I don't know if it's actually, Jill would know this more than me, but I think there's something really powerful about doing research related to suicidal thoughts and behaviors. We have patients who come into our studies at NIMH who are just so thrilled to be giving back, and that sort of the lowest point in their life can be used to help somebody else. And I think while we can't say that's a benefit of research, that is, a real powerful motivator. And I think that can really, that altruism and motivation to help people, I think in the long term can really have very profound effects.
I totally agree. So I did a study about suicide in people with schizophrenia, and it was a 2-year study. And that was exactly what people said. Having the opportunity to give back, to make a difference, was hugely important to them. And there was a lot of sadness when their 2 years were finished, and somebody asking and wanting to understand what it's like. I found if you're inquisitive about people and not just checking off a checklist, but you're really inquisitive about people, people want to help. They want to understand, and so they want you to understand so that you can help not just them, but everyone. And if you're open to listening to people's stories, they will tell you much more than you anticipate. And that's part of how we learn as well. We have our checklists, which are very important, but you could take that checklist and say it as if you're not reading a word or as if you're reading a word. And one shows you really understand what you're asking, and the other is, I have to fill out this form. And people respond to that. And treatment, people are uncomfortable. They don't necessarily feel well, and they get sometimes marginalized or ignored, or they don't tell anybody and nobody really knows. And then you ask them a question that they think nobody knows, nobody notices, and it just opens that door.
And I think as clinicians, we know that there's so many ways you communicate with a patient. And so there's a way, like you're saying, there's a way to ask the questions that implicitly communicates, you're not suicidal, are you? Because I really don't want you to be suicidal, or I don't want to worry about hospitalization. And instead coming from a place of, yeah, I want to know what it's like for you right now. Can you talk me through this? It's very validating, and you're going to get a lot more information. You're going to get a much more of a sense of somebody's suicide risk if you sort of come from that perspective. But there has to be the resources and support to deal, what if they are suicidal? What if they do need to be hospitalized that day? So you need to be able to deal with the positive responses. But I think there's a lot that we can do as clinicians to create an environment where somebody feels comfortable disclosing that. And it's not just like a checkbox.
Right.
Denies suicidal thoughts, check.
I think there's another part to what you're saying, which is because people used to think suicide can't be prevented.
Right.
So you sort of have to put somebody away until they're not suicidal anymore. But we've learned so much through research that most people who talk to you, most people who say yes, are not at risk for suicide. And so our knee-jerk response ought not be, oh, you have to go into the hospital, because in fact, until recently, there was no evidence that hospitalization reduced suicide risk, and there was lots of evidence that when people leave the hospital, their risk is higher. So now when you ask somebody the question, you don't have to worry as much. I mean, we as clinicians, we always worry, because who wants, we don't want our patients to feel that terrible, let alone die. But we have resources. We have interventions like the safety plan. There are new brief interventions like brief cognitive behavior therapy and CBT-SP, which is for suicide prevention, and dialectical behavior therapy. So now when we ask the question, we're not deciding, do I have to hospitalize this person or not? We're asking, tell me more about it. Are you thinking about it? What are your thoughts? How are you feeling? We together can make a collaborative decision about what the person needs, and even bring in family. So we don't have to decide, should we hospitalize this person or not hospitalize this person? And then all of that is built into your protocol. You still want to have safety checks. You want to have the opportunity to check in. We have 988, which has been very successful for reducing suicidal thoughts for people. So there are a lot of alternatives now. And I think the conversation is more accessible among everybody in the population. And so that opens up the possibility of just talking about it first and together making a decision.
And I think what's been so exciting, especially about this panel, is I completely agree. There's so many more resources. There's things that we know that they work. And then there's really interesting treatments on the horizon that are really promising. I mean, it's not going to work for everyone. But what was really striking, we talked about sleep and suicide. Maybe there's a cohort of people who benefit from sleep interventions, psilocybin and suicide with therapy. And so maybe that's an avenue for a particular patient that works for. And so I'm hopeful, I'm curious what you think, Jill, like next 5 to 10 years, we might know a lot more and can be a little more precise of, okay, this is somebody who would benefit from psychotherapy. This is somebody who could benefit from ketamine, TMS, and the whole gamut.
Yeah, because when we talk about, we have to predict whether someone's at risk or not, we're acting as if there's one line to risk. And the truth is, when we think about suicide, we think about there are a number of factors that if you're not well in those settings, that taken together, they could contribute to somebody acting on suicidal behavior. So having a mental health condition. Well, if your mental health condition is well, that pushes no, maybe not. People aren't like ticking time bombs. So having a chronic health condition, pain, family history of trauma. So a person has kind of a profile that may lead them to be at higher risk than somebody else, but it may never happen. But then in the context of stress, it might precipitate suicidal thoughts and behavior. And then if you have access to lethal means, you could die. So I think of that, I like that model because We can work on the underlying factors, right? We can work on managing social stress and managing the problems that are happening, and then we can also limit access to lethal means. So there's 3 opportunities and ways to get in there to reduce suicide. And so there's not one, this is the suicidal person. So of course, there's not one pathway to recovery. And we are learning more and more about that. We funded a study that measured brain function before and after dialectical behavior therapy. And it showed that the people who had less functioning there, they weren't deficient, they just had less functioning, actually did really well with dialectical behavior therapy, DBT. But people who didn't have that reduced functioning, it didn't really do it for them. I mean, eventually, after a year of therapy, they were better off, but they might have done better with a different therapy. And so that, like Elizabeth's saying, I think we're going to get to that as we both have more therapies and we have a better understanding of suicide. Not long ago, we had nothing.
Yes, right. But again, speaks to the importance of this keeping funded, people keep including these individuals and sort of not getting discouraged. I did a recent just look at the literature of like clinical trials related to suicide. I saw one recent review. It's like 100. It's something very small, and as compared to depression, it was 9,000 clinical trials related to pharmacotherapy of depression. So we just have to remember that there's this scale involved, that there's so much work to be done related to suicide, and if we keep doing this, we can really provide this more personalized treatment for our patients.
I also think that if we're excluding people who have just had a thought about it or even made an attempt, then who do you think these medications are going to work for? You've eliminated a third of the people, and so it's not a surprise that these things don't work for people who have more severe mental health conditions, and we have to include them. We have to study them. People aren't on the verge of suicide. When they're on the verge of suicide, that's a different state, but that's such an unusual state to be in, and we can intervene. There's so much we can do. It's a moment that passes. For the person who's in that, for lack of a better word, crisis moment or imminent moment, you can help de-escalate that if you know it's happening. That's the hard part. And then they will get through it, and they will be glad that they're still alive. They may still have all the same problems, but they will be able to work on them instead of being gone.
Yeah, I think really discussing kind of subsets and heterogeneity within the population of people who are at risk for suicide or who are experiencing suicidal ideation was really on display today in the panel too, even just from individual age groups. So looking from like adolescents to older adults and how that might manifest differently. And you talked about the importance of perhaps longitudinal studies versus cross-sectional. But do you think they're disparate kind of subgroups or along a continuum across age as well?
So we actually funded, we call it the lifespan study. We funded a study that there were 3 sites. It's our linked grant. And one site was a child site, one was sort of middle-aged adult, and one was older adults. And so each site did the same neuropsych tests, because we couldn't wait 60 years for somebody to get through all those periods. And then they also, to be methodologically sound, each site also collected some people from the other age groups. And what they studied was neuropsych and clinical symptoms. And what they found was that, and now I'm grossly generalizing, but that's okay. They found that the clinical symptoms really varied depending on age, but the neuropsych functioning was pretty consistent across the ages. There was a little difference between older people and younger people, but for the most part, the cognitive profile of somebody who was at risk for suicide stayed the same. And these were all people who had made an attempt. So they had engaged in suicidal behavior. So it was really interesting, but developmentally, the clinical symptoms did change over time.
Yeah, and I think, it's such a big topic, such a good question, but, you're thinking about, okay, at the adolescent level, you can intervene at the school level, you can teach them so they can identify it in their friends, the importance of sleep and school times. There's so much there, they're just starting to take drugs and use alcohol and what you can do at the prevention. And then at the older adults level, you might be more concerned about loneliness and social disconnection and chronic health problems. And so I completely agree. The essence, you're still worried about suicidal thoughts, intent, behavior, risk factors, but they're going to present differently. And critically, the environment is different just according to environmental stage. And so your interventions are probably going to have the key elements: increasing social connection, efficacy, instilling hope, but they're going to look quite different probably based on age.
Well, I want to thank you both so much for talking with me today. And that was a wonderful panel and a really wonderful interview. Hopefully, we've given some people things to think about.
Thank you so
Thank
much.
you.